طيب uh, good morning, good evening, ladies and gentlemen. I am very glad today to have Dr. Safaa Mohammed Hassan Eltayeb to talk about valvular heart diseases 2025 EAC point of view. And because we are late, Dr. Safaa, please welcome, and the platform is yours.
طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. I'm very sorry for this unforeseen delay and I'm ecstatic to meet everybody and to engage عبر الأثير من الدمام all the way through to الأبيض الكردفان الغرة خيرا جوا وبرا. My very sincere regards to all my colleagues, seniors, juniors, those are mentors, those who are still in training, and my very good friends. I'm very privileged with this invitation from Dr. Dasugi to not teach you, not to address you, but to share with you a few thoughts about the valvular heart disease as stated by the European Society of Cardiology and the European Society of Cardiothoracic Surgeons in this year, 2025. For those whom I haven't got the pleasure and the honor of meeting, my name is Safaa Mohammed Hassan Eltayeb. I'm a consultant physician in the first place, and I'm a consultant cardiologist in the second place, and I'm a consultant cardiac imaging. I'm a fellow of the London and Glasgow College, and I'm a fellow of the Society of Cardiac MR, which is the American Society of Cardiovascular MRI Imaging, and I'm accredited member for the European Society of Cardiac MR and Echo. So I'm very biased for echo and cardiac MRI. للمحة ولثانية I've had a glimpse of أستاذنا دكتور عبد الرحمن زيادة. يا أستاذنا عبد زيادة والله أنا يعني that you made my day. Seeing you has made my day. ما عايزة أخصص لكن it's just emotions running high. Without due or further ado, let me start talking about the outline of what I'm going to discuss this evening. I'm going to run the flag high for cardiac imaging as the modality to dictate the management, diagnosis, and follow-up of valvular heart diseases. And that has been reinforced in the year 2025 document from the European Society of Cardiovascular Imaging and the European Society of Cardiothoracic Surgeons. دسوقي لو في أي لحظة صوتي ما واضح أو you want me to stop, please let me know.
Everything is fine, Dr. Safaa. Please continue.
Excellent. Excellent. Okay. So I want to spend some time in this slide, and that's what appeared initially in this document. It highlights the importance of spending time analyzing and assessing valves on the mother and the grandmother modality for cardiac imaging, which is echocardiogram. Transthoracic echo and transesophageal echo are the two sides of the coin that has been there and tested over the years since the mid-40s or mid-50s, since the first machine of echocardiogram has been invented in Lund in Sweden. Until this age, echo has stood high on both transthoracic and transesophageal, and all the improvement by adding tissue deformation imaging, 3D imaging, and color Doppler, and what have you. It is still standing high in assessing as the #1 assessment modality for valvular heart diseases. Now, it's quite important that when we do echo, we do it with heart. يعني حكاية نعمل quick echo عشان نشوف, there's nothing called quick echo. You either do echo properly or you don't do it. This is a message. Diagnosis and quantification of valve dysfunction. And this is a statement that you can spend a whole night and a whole day explaining what is the quantification of valve dysfunction means. Cardiac chamber anatomy and function and damage and remodeling. On transthoracic echo, you are expected to comment on cardiac damage and remodeling. You can do that confidently by commenting not only on the calculated ejection fraction, but all the modalities there for you for global longitudinal strain, for TAPSI, MAPSI, velocities of the myocardium, you name it, it is there to tell you. Not only that, it's a modality that is always there for follow-up of echo of the valves after and during the treatment. Transesophageal echocardiogram is there to augment transthoracic assessment, especially in situations where the valve anatomy is not quite clear. Now, for the 2025, we have further imaging modalities, cardiac CT. Let me give you an example. A patient with aortic stenosis who got a very severe stenosis by virtue of gradient across the aortic valve. You sometimes need to answer questions. Is this valve truly that stenosed? Should I refer the patient for surgery? Should I refer for intervention? That could be augmented by cardiac CT telling you how calcific that valve is. And we have definite cutoff points for how severe the calcification is, or how mild or how moderate. And that could add to the definition and refining the specification of the stenosis of the valve. Cardiac MRI, there you go. That's a big player in the field. It is the gold standard assessment for chamber volumes and function. The right ventricle, which has notoriously been known as the part of the ventricle or part of the heart that hides behind the left ventricle, and it is not easy to quantify. This is a chamber that the best quantification and assessment is on cardiac MRI. There are many lesions. Let us name one of them, aortic regurg. Not infrequently, we come across situations where the aortic valve regurgitation is so severe, but we cannot align the CW to get a nice envelope because the valve is eccentric, the lesion is eccentric, hitting on the mitral valve and travels and hide behind the septum and goes spirally all the way. How can we track that sort of volume regurgitation? The only way is to quantify that with cardiac MRI. Now, the beauty of cardiac MRI, you don't have to go through painful calculation, equations. Like in echo, we have to calculate the volumes, you have to calculate the velocities. You sit back, you run your line, and the machine will give you exactly what the volume is without plus, minus, without upper, mild, without upper, lower, severe. Those words are not there anymore. Myocardial fibrosis is a future direction, or at least one of the future directions for judging how and when to interfere in lesions, isolated lesions like aortic regurg or mitral regurg. And that has put its impact on this year guidelines, the 2025, as we're going to see. Let me give you another example of how cardiac MRI can help in delineating the surgical management of valvular heart diseases. Think about a patient with severe mitral regurg or moderate to severe mitral regurg and a coexistent mitral annular disjunction. You know, and we know that mitral annular disjunction and mitral valve prolapse have high sudden cardiac death risk, and that is substantial in some patients. One of the best ways of assessing the risk of sudden cardiac death in these patients is to assess for myocardial fibrosis around the mitral annulus using the late gadolinium assessment in cardiac MRI. And having found that, late gadolinium enhancement on the myocardium or the mitral papillary muscles that can enhance the dictation of intervention, possibly surgery. And it is well known that surgical intervention is well reported and well known in many patients that surgical intervention for correction of mitral annular disjunction in many patients normalizes the ECG, removes the risk of sudden cardiac death, and normalizes the Holter assessment in these patients. How are we doing, Disugi?
Very fine, our queen.
Excellent. So this is a flag that we raise high, multimodality imaging, guys. Disugi ما في حاجة اسمها quick echo.
حاضر
تمام؟
حاضر يا باشا.
دايرين proper echo. تمسك الايكو بروب ده بحب تستعمله وانت تعشقه عشان يديك زي ما انت تديه.
حاضر ان شاء الله.
Right. Now, let's go to the first valve. أنا بالنسبة لي this is the most important valve. ليه؟ لأنه this is the most forgotten valve. We've had enough of long trials and assessment and treatment on the aortic valve and the mitral valve. And then we come and cross hands and say, oops, the patient has a severe TR. We don't know what to do with it. Let's go and assess the tricuspid valve. I will start with the tricuspid valve. Now, the tricuspid valve, to assess the tricuspid regurg, you need number one, to know why the valve is leaking. You need to study the valve nicely. You need to see the leaflets. You need to assess the coaptation sites. You need to assess the tenting sites. And you should assess the diastolic and systolic, diastolic and systolic existence of the valve. This is beyond the topic this time. I cannot spend more time in discussing. These are details on cardiac imaging, specific cardiac imaging lectures, but those are the things that are highlighted in 2025. Spend time on the valve, assess the jet size, see the triangular, nice big jet of the tricuspid regurgitation on CW, and then you do, whether you like it or not, spend your time on AROA, regurgitant volume, and vena contracta. It is painful, it's lengthy, but you don't have an option. It is a decision whether or not to take the patient to OR or not. It is a decision to refer the patient for tricuspid annuloplasty or not. And I will give you an example in the next few slides of a patient that we are stuck with because of failure of assessing the patient in her previous visits. Now, there are 3 reasons why the tricuspid valve can fail. Now, we have to acknowledge that we, as normal human beings, have a degree of tricuspid regurgitation, and it is mild. And that should not be there. This is nice, normal tricuspid regurg through nice, competent tricuspid leaflets. But if anything more than TR, if the TR is anything more than mild, if it's moderate, it has to be one of 3 causes. It's either secondary TR or device, cardiac implantable electronic device related, like pacemakers or ICDs or CRTs, or primary TR. Now, primary TR is the easiest because it is less than 10% of the cause of tricuspid regurg. Causes of primary TR are carcinoid, Epstein anomaly, rheumatic heart disease, these sort of things. But the majority of the tricuspid regurg that we deal with are the secondary TR, and these are the real pain. Why the TR is a real pain? Because it reflects back on the right ventricle, and right ventricular failure is bad news. This is one of the nightmares of every single surgeon. Now, we are mandated and compelled to study the consequences of the severe, not only the severity of the TR, and you start with delineating why the valve is leaking. This is number 1. Number 2, quantify how bad is the leak. Is it moderate, it's severe, and it's just not names. You have to give numbers. The AROA is that. The regurgitant volume is that. The fractional change is that. Then you go and assess the right ventricular function. Now, I want you to spend time on the mid column, the right ventricular function. I'll try to, right ventricular function. Every single assessment of the TR or tricuspid regurg, you should comment on the TAPSE, transannular excursion of the tricuspid annulus. It should be normally more than 17 millimeters. We know the cutoff point is 17. Anything more than 17, you are high and dry. You should run your PW cursor on the lateral wall and assess the velocity. It should be more than 10 centimeters. You should measure the global longitudinal strain, and just like the left ventricle, it should be more than 20%. The numbers are equivalent. And you should assess the fractional area change. I don't want you to spend time doing the ejection fraction because it's not well validated. Yes, the guidelines will tell you that, but the images are not quite allowing. The only modality that can accurately give you the right ventricular ejection fraction is the cardiac MRI. And until you have that, please use your nice echo machine to assess the fractional area change, which is quite equivalent to right ventricular ejection fraction. Now, the numbers are there for you to download from your mobile, from any app, and you have to spend time doing that for every single patient. If the patient TR is severe, and the right ventricular function is bad, you should think 100 times before referring the patient, because he will not come off bypass. Before we make that decision confidently that the patient is deemed inoperable or not, this is a banned or indication to refer the patient for right heart cath to measure the pulmonary pressures. Now, I want you to think about this patient. Disugi, I'm sure you've seen that. And يا جماعة معلش أنا I keep addressing Disugi لأنه Disugi ده ولدنا. He's still my junior, and I have to poke on him every now and then. معلش يا Disugi استحملني
لا لا
شوية.
لا لا, welcome يا boss. I'm very happy with that.
Right. Okay. Disugi, how many times have you seen TR that you thought 100 times, what are the possible causes of this TR? Especially if there is no left side pathology. I'm sure not مرة, not مرتين, not ثلاثة. So many times.
Yes.
Not every TR is simple. Now we have a clear distinctions of the TR. Good news. We have secondary TR, which is either atrial or ventricular. This distinction into primary TR or devices related TR دي اتكلمنا عليها. قلنا primary TR is either Epstein or carcinoid or rheumatoid. But look at the left-hand side. There is a new definition of a secondary TR. This secondary TR is isolated tricuspid regurg, which is either ventricular secondary TR due to disease of the right ventricle or atrial secondary TR due to disease of the right atrium. شفت كيف؟ حكاية ماشية لقدام. And not only that, we now know how to differentiate between which is which, but that has to be by using the whole modality on the echo, assessing the vena contracta, tricuspid anatomy, and 3D assessment of the valve area, and the CW. Last but not least is the cardiac MRI on the bottom side. Why is that important? This is very important because the decision what to do with these patients is very, very important. There is a very landmark paper produced by the giants of European Society of Cardiovascular Imaging, Victoria Delgado, Rebecca Hahn, Luigi Badano. This is a very landmark paper that I would advise each and every one of us to read it by heart. Atrial secondary tricuspid regurgitation, pathophysiology definition, diagnosis, and treatment. Because this paper has dictated what we do with these patients, and it did shape the guidelines for 2025. So roughly, the atrial secondary tricuspid regurg, there is either atrial secondary TR, either is clinically relevant. It's mostly in patients that the right side, actually mainly the right atrium is dilated, while the right ventricle is normal size. The tenting of the tricuspid valve is not severe, and the right atrium is enormous, and the tricuspid regurg is severe, and this is mostly in patients with atrial fibrillation. لما نمشي لقدام في mitral valve, you would know, and you will get to know, there is a similar process going in the left atrium. So there is secondary tricuspid regurg and the secondary mitral regurg, and in the presence of atrial fibrillation, it mandates ablation or restoration of sinus reason, because this is one of the very few medical options to revert the progression or to hold the progression of the tricuspid regurg. Another very important parameter that we should know about, and it is there whenever we go to meetings on cardiac imaging. It is called the TAPSE over pulmonary artery systolic pressure ratio. Very easy. Measure the TAPSE, measure the pulmonary artery systolic pressure through the TR, and the magic number is 0.36 or 0.35. This is a universally applicable non-invasive measure and surrogate of RV pulmonary artery coupling. These numbers, it tells you on site whether the patient is too late or is still optimal for surgery. And the results are more or less similar to what you're going to get on right side cath. This is what the guidelines tell us about the workflow on patients with tricuspid regurg. If the patient has left side heart valve goal into mitral valve surgery, and you need to refer the patients for surgery, go and assess the tricuspid regurg. If the tricuspid regurg is mild and the tricuspid annulus is less than 40, you don't have to operate. That's what the guidelines tell us until now. But when you go and see the gaps towards the end of the document for the guidelines, they will tell you, we need more time and more data on these patients. But it says again, if you have left side heart surgery for mitral valve or aortic valve, and you're going for surgery, you have to operate on the tricuspid valve if it's anything more than moderate. While like the patient اللي قلنا عليه primary TR, لو ما عنده left side surgery, you assess if the TR is severe, you have the option to refer the patient for all the way between medical therapy is a kind of RV function is non-recoverable, or you still have the option of transcatheter therapy. I'm saying this لأنه this is very, very practical. I had a patient actually this is one of الباكلوج بتاع الحرب يا دسوقي.
Yes.
She came to see me قبل 3 شهور, and she was so bloated. She had atrial fibrillation. She was already followed up هناك عندنا في السودان, and she was scheduled for tricuspid surgery on 2 occasions, لكن ربنا ما قدر عليها. She has atrial fibrillation and she was an anticoagulant because of her atrial fibrillation. Her left side was absolutely normal mitral valve, normal aortic valve, normal left ventricle. عندها severe TR with right side was normal TAPSI, لكن الرايت atrium بتاعها was enormous. بمعنى كلمة enormous, and the tricuspid regurg was what I call torrential. Accordingly عندها liver محترمة. This as a backlog of the severe TR. Now, this patient, she came bloated with right side failure. Actually, when I referred this patient for tricuspid valve annuloplasty, actually I referred her for tricuspid surgery. It was quite a journey, and جاية زيارة. It was a very, very difficult story. But the end result is, she ended up having a nice tear, transcutaneous end-to-end anastomosis of both or approximation of the leaflets, and miraculously this lady has had her phenotype transformed. The liver disappeared, رغم إنه diagnosis was there for more than 10 years. And that's what the guidelines tell us. The tricuspid secondary TR prognosis is much better than the mitral secondary TR, because the tricuspid annulus is different from the mitral annulus. The tricuspid annulus has less fibrous tissue than the mitral annulus, and the right ventricular ability to compensate for that is much better. So always try to interfere, no matter how late the patient is. So that was the message. Let me take you this patient. الفيديوز واضحة معاك يا دسوقي؟
We see still images. We didn't see video. Yes, now. Yes, very clear.
طيب, as you can see, this is a patient who has severe TR. يعني أنا ما محتاجة أحط لك كلر عشان تعرف this is severe TR. You can see this is a patient who has a mitral tissue valve, and you can see that the tricuspid valve is patulous. It does not close. This is a patient whom I've seen 4 days ago. She's coming with bloating, dyspnea on exertion, mild lower limb edema. Now, this is her mitral valve. She had a tissue valve replacement قبل 15 سنة for a rheumatic heart disease, and she had it actually. I think she did well. يعني قعدة for a long time. I think that was a good thing. But the idea is, at the time of the mitral valve surgery, the tricuspid valve was deemed mild and not needing intervention. And that's what happened 15 years later. still الميترال valve بتاعه ما بطال شغال في mild leak. But look at the tricuspid valve. Look, it barely collapses. Now, I'm sure لو استقبلنا من أمرنا لما استدبرنا, this patient should have had tricuspid valve angioplasty, لأنه now I'm at a stage where if I referred her for tricuspid valve annuloplasty, I probably would need to get her mitral valve to be replaced. حتى لو عنده paravalvular leak ولو بسيط. في اوبشن ثاني، لو البارافالفولار leak في الميترال ريجاج في الميترال فالف is بسيط، ممكن نخليه يعمل لها كلودر ويعمل لها tricuspid end to end anastomosis، نعمل لها تير. These options is exactly what is meant by heart team decision. This is a patient again رحمنا سودانية جاية نازحة. She had her mitral valve replaced قبل 15 سنة and she's coming with heart failure, and we are talking about an operation that could cost an arm and a leg to get it done. This is a situation what we have now. So the heart team discussion now أنا ما عندي خيار. She's only 50. يعني اللكجري بتاعت إنه أقول لهم أعملوا لها تير ولا أعملوا لها، لا. I have to understand what to do. This is a situation that can be quite dismal. These are the things that should be considered before operating on this patient. I'm sure if the surgeon استقبل من أمره مستدبر 15 years back, he would have annuloplasted her tricuspid valve. And that's the price we make, and that's the price we pay later. So this, to conclude, the tricuspid valve, you can see the outlines on the left-hand side, very important, raising the flag of careful evaluation of the tricuspid etiology, the stage of the disease, and the patient operative risk and likelihood of recovery by the heart team. And what's very important is what you have here is concomitant tricuspid valve surgery is recommended in patients with severe primary or secondary, but what we have more is transcatheter tricuspid valve treatment considered to improve quality of life in patients with or without left-sided valve اللي هو الناس اللي عندهم primary valve disease. But this is very important. For tricuspid valve, people are now moving towards intervention by percutaneous intervention, TEER, tricuspid annuloplasty, percutaneous tricuspid annuloplasty. All these options are there, which is أنا أفتكر فتح كبير بالنسبة ل lots of patients who are difficult to operate on. Moving away from the tricuspid, going to the mitral. بالنسبة للprimary mitral regurg, which constitute 50% of the mitral regurg, I don't think we have تغيير كبير من 21 to 25. But what we have to highlight here are two things. The tier now, because intervention cardiology is getting very, very up on the edge of the choices. And what we have now is, you know, the collection of patients who have very calcific mitral valve. يعني يجيك elderly patient, frail, عنده severely calcific mitral valve. And this calcific mitral valve اللي هي mitral annular calcification in whom the calcification has extended all the way to the valves. It rarely causes degenerative severe dysfunction of the valve, but sometimes it does. Now we have the option of transcutaneous mitral valve implantation similar to TAVI in this group of patients to avoid surgery. We know surgery in these patients is very, very heroic. It ends up a lot of, you know, bleeding because of the calcification, a lot of aneurysms, and a lot of complications. Now we have this option for transcutaneous mitral valve implantation. دي بالنسبة للprimary mitral valve. The secondary mitral valve regurgitation, similar to the secondary tricuspid valve regurgitation. This is again, we are compelled to distinguish atrial versus ventricular. يا جماعة ventricular secondary mitral regurg cohort of patients is easy. Patients who have ischemic heart disease, patients who have left bundle branch block, المهم multiple wall motion abnormalities, very dilated left ventricle, very multi-dysfunctional segments on the 17 segments of the left ventricle, ending up in a dilated left ventricle with secondary mitral regurgitation. While there is a group of patients with significant mitral regurg where the left ventricle is normalish, if not small. The left atrium is significantly dilated, and the mitral regurg is severe. These are two distinct types of patients with secondary MR. The distinction is important because the patients with the ventricular dysfunction with secondary mitral regurg should be optimized all the way through to CRT. And sometimes that is enough to bring them back into normal or mild or mild to moderate MR, which is tolerable. But for the atrial secondary MR, those patients are quite difficult to control. And these are the types of patients in whom we have to exercise all the options, including restoration of sinus rhythm and use of SGLT2 inhibitors as the main stand, and of course the 4 pillars. Now, ya Jamaa, we have, I'm sure you agree that the 4 pillars, especially the ARNIs and the SGLT2 inhibitors, they stand as a cornerstone for at least normalizing or minimizing the chances of atrial arrhythmia, especially atrial fibrillation. So this is part of the treatment. And if these patients failed on this treatment, just like the tricuspid regurg, you have to start antiarrhythmic. And you exercise all the possible options to try to bring these patients back into sinus rhythm. And if that failed, the patients have to go for surgery. It's not a joke. You have to get the patient for surgery. And actually thinking back, I have seen many of these patients and I did not know why their MR is so severe. Now we have a very clear distinction of a definition of atrial secondary mitral regurg. And we should all be aware about that because these patients have to be referred for mitral valve surgery and tricuspid as an anterior if indicated. And that is how we distinguish between them. This is a very, very fantastic presentation by Zughbi. William Zughbi has done a fantastic work on distinguishing and dichotomizing the mitral regurg into atrial secondary mitral regurg or ventricular secondary mitral regurg. So in those who have ventricular, you can see the left ventricle is large, it's bulgy, it's bulky, it's irregular, while those with the secondary atrial, they're the classical atrial fibrillation, the atrial, the classical HFpEF left ventricle, smallish, normal size-ish, with huge left atrium compared to the left atrium, which is dilated in the secondary MR. Not only that, the MR in those patients with the atrial MR is very, very, very central. It hits the roof of the left atrium, while those patients, it is actually either eccentric or it could be mildly central, but mostly eccentric, or it could be spiraling up all the way the left ventricle, the left atrium. This is how they look in the left in the MRI, and this is how they look in the cardiac CT. The best example of these patients is patients with heart failure with preserved ejection fraction, and the best is actually patients with cardiac amyloid as they progress. Knowing the patient with cardiac amyloid, follow their echo as they deteriorate. هتلقى الميترال regurg بتاعهم starts from a small puff or transition from a small puff to mild to moderate to severe, and that is just one of the causes of death in these patients. Again, illustrating the importance of this, and it says clearly that this group of patients, recommendations in intervention for secondary mitral regurg, severe atrial secondary mitral regurg is class 2A. يعني استناها الجايدلاينز الجديده بتجيك class 1A. ليه؟ لانه now we know how to diagnose these patients, we know how to distinguish them from other causes of mitral regurg, and it says you have to refer them all the way mitral valve surgery, surgical atrial fibrillation ablation, and isolation of the left atrial appendage. Not only that, you have to subject them for TEER, and it might be considered in symptomatic patients with severe atrial secondary mitral regurg, not eligible for surgery, or after optimization, you tried them on the 4 pillars, you tried them on everything, and they are still there. شفت كيف هذا سوق الموضوع ماشي خطير، ماشي حكايه ماشيه زايده.
والله بص، لكن ما شاء الله.
it is there, البوينت is there. كل ما تفكر هتلقى انه yes I have come across one or two of those patients، مريت عليهم، لكن it's so nice to know that they are now well clarified, they are well classified, and they are well demarcated, and we know what to do with them.
Yes, exactly.
Now going to the old friend, aortic stenosis. And I'm not going to spend a lot of time on aortic stenosis. And I think this is a valve that continues to intrigue and to attract lots of attentions. But what I want to highlight is that all the classification and quantification of aortic stenosis depends on dedicated echo assessment. Still, ما بتقدر تبارح this platform, the Vmax and the mean and the aortic valve area. في حاجة مهمة in this context, they keep talking about it in this regard, which is the dimensionless index. What we learned all the way, the dimensionless index, which is just to remind you, is the ratio between the LVOT and the aortic gradient. This is one assessment parameter that is hardly affected by the hemodynamics. We know that we can overestimate the gradient, we can overestimate the velocities, we can overestimate a lot of things when the patient is anemic or thyrotoxic or in a shock state, or the blood pressure is uncontrolled and these sort of things. And we're always requested to repeat the assessment when the patient is well optimized. However, the dimensionless index is the one index that is not affected by any of this, or hardly affected, not only on native valves, but also on valves that are replaced. So that's what I urge everyone to use and train yourself to do it periodically. So on your left-hand side, the use of transthoracic echo, augmenting it all the way with dobutamine to fragment patients. Now, يعني on your left-hand side, again, a flow chart is what we do every day. ما في حاجة مختلفة. But what I need to highlight is there are new players in the field. The use of BMP in these patients. And that's one thing we have, I think, as per the guidelines, we have to do routinely in patients who are between two brackets asymptomatic. But who أصعب حاجة إنك you say the patient is asymptomatic. Who a patient asymptomatic that we all know they train themselves and their body to slow down because of the impact of low cardiac output. But try to exercise them as the guidelines tell you what to do that. Exercise test to see what the blood pressure do and what the symptoms happen. You will be surprised. Many of them, they develop symptoms with very low effort workload. زي ما كان بيقول واحد من very early mentors بتاعنا, get the patient to climb to the roof and go behind him because he might arrest halfway through. This is how you expose symptoms. Of course, if the patient has BMP, this is one of the other things. Of course, we've mentioned earlier about the use of a calcification index on the aortic valve in patients when using the cardiac CT. An ejection fraction, and I want to spend just 1 or 2 minutes here about it. We have to be careful interpreting ejection fraction in patients with valvular heart disease. Patients with valvular heart disease have a lot of things. They have bundle branch blocks. They can, and that can change the systole and diastole parameters. When we talk about ejection fraction, we're not talking about the M mode assessment only. Please go and use your Simpson module. لو ما عندك اي حاجه قدرت تعملها او عندك اي حاجه انت مستعجل, بس اعمل لهم a good decent Simpson module on the 2 chamber and the 4 chamber. كده انت بتكون حقيت الايجكشن fraction, لانه a cutoff point بتاعت 50 بتاعت 55 it makes a difference between categorizing the patient as severe or low. وده بالنسبه لل AS is one side. Remember, in AS patients يا جماعه, there are many types of left ventricular hypertrophy. A left ventricle for aortic stenosis can have asymmetric septal hypertrophy. It can have eccentric hypertrophy. It can have apical hypertrophy. All these are well described. If you fail to take all that into consideration, you will come up with the wrong ejection fraction. And the last thing you want to do is to dismiss the patient as come in 3 months' time or 6 months' time for follow-up, and the patient drops dead shortly afterwards. دي مسؤولية. You don't want to shoulder it. Please give time for proper, decent, passionate echocardiographic assessment of ejection fraction in these sort of patients. لو في عندك أي doubt exercise the patient. ما هتكلفك حاجة. ما عندك exercise ماشين خليه يطلع السلم. Get him to hit the roof and come back. لو تماها وجا راجع بعد ده you are safe high and dry. خليه يمشي البيت يجيك بعد 3 شهور وجاي من السنة بتلقاه الواطة. Now, this is what we have. This is a classical situation where we can exercise all the options from Ross procedure to the fancy TAVI according to the age. All the options, all the menu is full. Get your patient, assess him, his life expectancy, his quality of life, your center experience, your resources, and you have to decide what is good for your patient and talk to him. Most of the patients in this day and age have got their access to this media and they know what is best and they surprise you. They would come with all the options already. يا دكتور أنا ليه ما أعمل روس operation؟ ليه تعمل لي تافي؟ ليه تعمل لي mechanical valve? Why I don't want anticoagulation? And it is their right, especially if he is paying for the procedure. You don't have to play God in this sense. Now, this is interesting. I want to spend time in this. Aortic regurg. Aortic regurg is another big challenge. And I think aortic regurg is one of the most difficult lesions to assess. Never, never, never underestimate aortic regurg. And aortic regurg, once it brings the patient to the hospital, it is significant. It is the only murmur, the diastolic murmur, لما تسمعها بالسماعة, if people still are using the stethoscope, إذا سمعت الأورتيك ريجل بالسماعة معناها إن it's at least moderate. ما في mild AR بسمع بالسماعة. Once you listen to AR blowing the diastolic murmur on the left sternal edge, you know that you are dealing with a good diastolic murmur, especially if the difference between the diastolic and systolic pressure is high. An exercise of the basic knowledge on the bedside is very, very yielding in patients with valvular heart disease, and I think aortic regurg is one of them. You have to quantify and assess why the aortic valve is leaking, and there aren't many reasons for that. Either the valve is having a large coaptation defect or abnormal valve morphology, that like what we have in patients with rheumatic heart disease, or a perforated cusp, or a flail cusp that we do sometimes see in patients with connective tissue diseases. Assessment of those patients is easier for EROA and regurgitant volume and the vena contracta because of the left ventricular outflow tract ratio. لكن what you sometimes do face, زي ما قلنا earlier, the very eccentric jet of an otherwise severe AR that hinds and sweeps all the way behind, hit the mitral valve and hit the roof of the apex of the left ventricle and goes back. This one sometimes you cannot chase on echo. It is sometimes difficult. ولما تاخد البروب for CW, it sometimes is beyond your reach. You have to look for that carefully. Not only that, but you are compelled to look for evidence of left ventricular damage. Left ventricular damage is one area where you have to look carefully into dimensions of the left ventricle and the index volumes. And المشكلة إنه index volumes are rarely used on echo. يعني most of the machines, actually all the machines are there, they have the capacity to tell you the height and the weight of the patient, and if you did that, it will give you the index volumes. But people don't do that. This is why most of the people have ended up needing the support of echo like CMR. أديك example يا دسوقي. Patients with bicuspid aortic valve. Bicuspid aortic valve due to, for example, fusion of non-coronary cusp and right coronary cusp. The jet is eccentric. The aortic root might be dilated either on the aortic root or distally, and there might be coarctation of the aorta, and there might be a PDA. We are عارفين دي يعني categorically from the congenital point of view these can happen. اصل انت ما ممكن عيان يكون عنده bicuspid aortic valve ما تفتش الاورتيك root وما تفتش for possible coarctation. This is a standard. If it is there, you manage to find a very good view for the aortic root and you measure it, you still have a blind window. We all know that the echocardiogram have a blind window for the ascending aorta. And once the patient is diagnosed with a bicuspid aortic valve, which is severe enough and mandating intervention, you have to refer the patient for either CT or cardiac MRI to assess the aortic root, to assess the distensibility of the aorta, to look for possible coarctation, and to look for possible PDA. These are mandatory. One of the most fantastic transition of medicine is the use of TAVI as an option for treatment of patients with inoperable aortic leakage. And this is appearing in 2025 ESC guidelines as TAVI class 2B, as you can see on your bottom right hand. Yani it is so amazing. TAVI over the years has traveled mean trileaflet aortic valve stenosis to bicuspid aortic valve stenosis, and in some cases now ماشي لحد AR. Look at this transition of this technique now addressing such issues. I think this has been brought by the advances of using the modalities like cardiac MRI and the CT to delineate the anatomically reasonable anatomy for the aortic valve and aortic root to accept that. In the year 2017, in the year يعني 2017 افتكر دي كانت 2017, yes, that was I think one of the first papers that talked about safety and efficacy of transcatheter aortic valve replacement in the treatment of pure aortic leakage. To be honest, at that time in 2017, the results were not encouraging. There were lots of disappointment because of severe paravalvular leak, as you would imagine, and there is migration of the device. Look at what happened in this 2024 in April, and I think that is a paper that actually brought the guidelines to confirm the possibility and the feasibility of TAVI as an option to treat severe aortic leakage, transcatheter aortic valve implantation in patients with symptomatic native aortic regurgitation. Now, they do have bits and pieces about, Dairine, very dedicated catheters and devices for this sort of lesion, and there is a chance of higher need for pacemaker post procedure. Like in the end, there is less incidence of paravalvular leak, and there is a less incidence of complications. I did not want to go and dive into other options. Of course, I cannot discuss the whole of the document in this time frame. It's such a fat document with plethora of informations. Like as far as I'm concerned, these are the most exciting things that has came up compared to 2021. And I think it refined, and it's going to refine, and it should refine our practice in daily practice in valvular heart disease. This is my last slide, and I'm concluding by what the document has brought in the introductory page, that the importance of shared and patient-centered decision-making by a multidisciplinary expert heart team within a regional network. You have to know your feasibilities, your experts, يعني نواقصك التمام وين الكمال وين, how to fund these are important, and whether we like it or not, they're going to govern the decision. Just like the patient I showed you, she is in need for intervention, لكن أنا يدي مغلولة بإنه this patient has no support, this patient is not a native, she's not a local, but she needs something to be done. The importance of correctly assessing the cause and mechanism of the valve lesion. وده لن يتأتى إلا ب a very dedicated, very cautious and very passionate assessment of the valve lesion, mostly on the mother and the grandmother of all cardiac imaging modality, which is echocardiogram, and last but not least, growing knowledge and confidence of using multimodality imaging has refined the patient referral for interventions once deemed a contraindication like a bicuspid aortic valve. يعني 2 weeks ago, I had a patient with a bicuspid aortic valve and a CA head of the pancreas. He's only in his late 40s. He was deemed يعني asymptomatic post
فارس
Whipple
فارس
surgery. He
فارس
had he had a
فارس
severe pulmonary.
Please, Dr. Safaa, unmute yourself, please. Dr. Safaa? Hello, Dr. Safaa? دكتور صفا.
الشكل ما سامعك يا زوقي.
ايوه دقيقة اشوف. دكتور صفا please unmute yourself please.
انت من وين انا بتكلم براي؟
ما
معلش.
بعرف حاجة.
بتكلم براي من 200 اخر حاجه وقفت معايا. وين انت؟ ارجع لي من
يعني
وين تاني؟
around 30 minutes 30 seconds كده.
يعني آخر حاجة قلتيها الحاجة دي يعني.
صلاح الباشا كيفك يا اخي؟
وانت كويسة؟
الحمد لله.
والله أنا مستمتع جدا 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 بجد والله.
يا الله عليك يا باشا يا اخي. It is my شوف يعني the glory of this meeting is to engage with people like yourself يا
كتر
باشا.
خير، كتر خيرك يا صفا، حفظك ربنا.
بارك الله فيك.
الله يبارك
بارك
فيك.
الله فيك.
شكرا.
Okay دسوقي I'm ready. Any questions?
uh,
Any
okay يعني really this is more than amazing. ولو سمحت لي أستاذنا بروف الباشا وأستاذنا دكتور عبد الرحمن زيادة to say دكتور صفا is the queen of our cardiology community. and قبل ما نمشي للأسئلة دكتور صفا أنا عاوزك يعني توعدينا. بل يعني بالمناسبة السودانيين معظمهم موجودين هنا ومعظم الناس يعني ما حضروا. وأنا منهم أستاذنا بروفيسور محمد حسن الطيب. والحقيقة يعني فرصة طيبة جدا إنه الناس يعني زي ما بيقولوا يسمعوا منك يعني. فتعيدين إن شاء الله كل شهر 6 weeks يعني تكوني معانا in the platform إن شاء الله.
والله يا دسوقي it's my pleasure وأنا at your disposal. ورحم الله الوالد يعني ونأمل إنه كل اللي بيعمل ده يمشي له وأجره لأنه يعني we are his products. ربنا يرحمه ويغفر له ويغفر لكل أساتذتنا الأجلاء. و ده أصلا ده الصدقة المستمرة والجارية بإذن الله بإذن الله.
الله
وأنا
يديك.
والله دسوقي I'm very proud of what you do in terms of work. ويعني looking from a distance at you وانت في الأبيض زي ما أنا كتبت قبل كده your work is dwarfing most of us. يعني بننظر إليك يعني بعين الرضا. ويعني ربنا إن شاء الله ييسر الأمر ونقدر نرجع to fight along with you to fight medically at least. حتى لو ما قدرنا to fight congrats to fight medically عشان نقدر whatever left of our life نكون productive بالنسبة للبيشنتس ونديهم من العلم اللي تعلمناه والاكسبوشر اللي تعلمناها وكلها تكون صدقة جارية لأنه ده اللي بيبقى في النهاية.
الله يديك العافية وصوة كتر خيرك كتير. لو سمحت لي أستاذنا بروف الباشا أنا عاوزك تقدم أستاذنا دكتور عبد الرحمن زيادة هو معانا موجود هنا. وافتكر الفرصة الأولى تكون له. Please بروف الباشا welcome to introduce our great teacher دكتور عبد الرحمن زيادة.
قبل ما أقدم البروف وأستاذنا عبد زيادة، لكن دار أقول للأخت الكريمة الفاضلة صفاء حسن الطيب، كلنا إحنا صدقة جارية للوالد حسن الطيب، كلنا علمنا. والزول لما يسمع لمحاضرتك دي يعرف فعلا يعني الجين بتاع عظمة التيتشنج والفن بتاع توصيل المعلومة جا من وين؟ والله we enjoy everything of it. مش واحدة من المحاضرات، والله إن the best lecture سمعت عن الفالفولار هارت ديزيز. شكرا لك كثير يا الأخت الكريمة العزيزة صفاء والبيني، وشهادتي دائما في صفاء بتكون مجروحة دائما. أنا it is my honor وماي pleasure أقدم أخي الكريم الفاضل العزيز الراقي دكتور عبد الرحمن زيادة. عبد الرحمن زيادة is the one of the best teacher، ودي كلنا جماعة من صنع أستاذنا وأبواتنا محمد حسن الطيب، بروفيسور صديق أحمد إسماعيل رحمه الله، والإخوة يعني الجيل الأوائل. عبده كما يحلو لنا أن نناديك عبده زيادة. the floor is yours. عبده ده كان رئيس جمعية القلب السودانية، واحدة من الدورات الممتازة. عبده شارك في وضع التريننج بورد بتاع الكارديولوجي بتاع في السودان هنا، وكان الكورنر ستون بتاع التريننج بتاع التيتشنج بتاع الاجتماعات اللي بتعملها كان شهريا. وعبده افضاله لا يمكن الزول احصاها، ورجل يعني راقي ومؤدب وعالم ونلجبل. تفضل يا عبده.
السلام عليكم ورحمة الله.
عليكم السلام
عليكم
أستاذ.
السلام ورحمة الله.
في البداية يا صفاء، كل ما يذكر اسم المرحوم محمد حسن الطيب أنا تنتابني رعشة وانحناء، فهو الأستاذ الأول، وكان بالنسبة لي المهذب الأول، رحمه الله رحمة واسعة. والحقيقة يعني كثير مما نقوم به الآن مبني على أسس وضعها في دواخلنا، رحمة الله عليه ثم رحمة الله عليه. إن شاء الله ربنا يتقبله في الصالحين، ونرى يعني في وجهه نظرة النعيم بإذن الله تعالى. ويا صفا, I have immensely enjoyed this journey through the development in the management in valvular heart disease. ودائما أنا I had a nostalgia about echocardiography and eventually imaging, and I thought that the direction بالنسبة للfellows في training إنه these modalities have to be given attention. وواقع الأمر, if you look at the development throughout time, one of the things that moved clinical practice from guesswork, what we call clinical assessment, which can be varied between different physicians, into actual figures that makes science, that enables people to do the assessment in figures, and consequently transform that into clinical practice and outcomes as far as the patients are concerned. Imaging في الأول requires a lot of imagination, and the first confirmation of imagination has come from postmortem studies, and eventually that gave people the imagination as to what happens in pathology, comparing it to the normal. Well, I remember the first book that I saw about CT scan, the book title was Naked to the Bone, and Seeing is Believing. وبالتالي كنت أنا بفتكر إنه always the attention in training, particularly to the fellows, is first of all to develop this imagination, take this imagination into imaging modalities, understanding things, and eventually transform this into something that you can give to the surgeon to do things perfectly well. This, I think, up to now has not been achieved. And if you notice in the podcasts of the European Society of Cardiology guidelines 2025, they still talk about the difficulties. They still talk about the limitations. But we have to appreciate the fact that our current status in Sudan makes the limitations vast. We don't have up to now anything which would suggest that what we see is matching what the surgeon does, is matching the outcomes to the patients. And I think the message here is to concentrate in the future إن شاء الله كلنا نرجع لذلك البلد. ولكن هذه المهمة أنا بفتكر إنها أصبحت مهمة صلاح الباشا ودسوقي وصفاء إلى آخره, is to give this modality the upper hand in clinical practice and in the training of fellows. We have to go away from the thought أنه سنام الطب في مكان آخر. سنام الطب is not in the catheter lab, and سنام الطب is in the clinic and the imaging modalities. And I'm very, very pleased to see على إنه Safaa has put clearly the correlation between her imagination, knowledge, and the introduction of the patient to the surgeon or to the interventionist. Thank you very much Safaa. وأخونا صلاح الباشا هنا وصية يا صلاح أنا قلتها قبل كده في one of the meetings. The future is imaging, imaging, imaging. وأنا قاعد هنا دلوقتي في the temperature is, by the way, outside is -2 degrees centigrade. I'm pleased that my tongue has had still a bit of movement to say my impression. لكن يا صفاء I have immensely enjoyed this talk. حاجة تانية, I really, really appreciate the enthusiasm and the efforts of Dsugi. I have been seeing a number of webinars and Zoom meetings that he conducts regularly. Quite a few I didn't complete because of the difference of time between here and there, but it's an amazing capability that in such circumstances in that part of the world نحن بنعزه معزة شديدة جدا جدا ونتلوى كل يوم في ذكراه, that he is doing this enormous effort to put us together. يعني أنا I never knew as to when I'm going to hear your voice again, ولا أسمع صلاح الباشا 200 إلى آخره إلى آخره. Thank you very much يا دسوقي, and keep it on.
إن شاء الله.
وهي بقدر ما إنها بتديك البليجر والبرستيج, بترمي عليك مسؤولية ضخمة جدا جدا since you took البوينتر تو بوينت towards الكلينيكال براكتس والمشاكل.
السلام عليكم دكتور دسوقي.
عليكم السلام ورحمة الله. مرحبا بك، تفضل.
Can you hear me?
يس تفضل، مرحبا بك.
أنا عز الدين ساوي.
يا مرحبا بك دكتور عز الدين، تفضل أستاذنا.
كيف حالك؟ أول حاجة يعني شكرا لك وشكرا للدكتورة صفاء، وما عايزة أتكلم يعني زيادة على الكلام اللي قالوه الجماعة قدامي، إلا أن أقول هي من ذاك الأسد. فنشكرك كثير على هذه المحاضرة الجميلة. نمرة 2.
I'm so pleased with your comments, and I'm so pleased and I'm يعني flattered by all the comments, وكلها من زملاء قامات كبيرة, and I'm so pleased to communicate with everybody through this limited time. لكن بالنسبة لي it was enormous. Thank you very much for the feedback.
سؤالي يا دكتورة صفاء، في discrepancy في الجايد لاينز الامريكان ولا الاي اس سي جايد لاينز for evaluation of the exercise test؟ وانا I believe although this is might be simple test لكن very important and crucial in the decision making. Drop of blood pressure 20% in the American, drop of blood pressure 10% in the ESC guidelines to make a positive exercise test. And I think this is a very good, which you are in favor. And the other thing is that in patients with severe aortic stenosis, in fact, I didn't I didn't hear the end of the lecture because the line was interrupted. But if this was not mentioned, in patients with severe ejection severe stenosis aortic with normal ejection fraction who are asymptomatic. The role of calcium scoring.
طيب
So I'd like you to comment on that.
اوكي بالنسبه للسؤال الاول I am هي صحيح discrepancy between 10% to 20% between the Americans. It's always there, the discrepancy between the Americans, but I think it's quite mild. The best way to answer is you don't look at one figure, you look at the whole picture. Yani if the patient dropped his blood pressure by 10% and there was significant change on, for example, the ST segments on the ECG while he was exercising, whether on the treadmill or on the bicycle, and at the same time there were symptoms, I think I would read the whole picture. يعني ما حخلي patient to continue exercising until he drops the 20%. As the Americans say, if I am seeing alarming signs, I see the bigger picture. It's always significant enough for me to get the patient down as this is severe symptomatic aortic stenosis. For the second part, yes, probably that was missed in the line disconnected. Yes, we do assess the number at the number for CT, the calcium score on the aortic valve, and that helps enormously. ودي أنا قلتها in the very beginning of the lecture لأنه الموديول which has been produced by the ESC has included the multimodality imaging for the cardiac CT and the cardiac MRI, and I gave the example of the estimation of the calcium score on the aortic valve in patients who have is that severe enough or not. So it adds to the severity assessment. Yes, definitely there, and we know about the cutoff point for males and for females being significant stenosis or not, even if numbers did not match up on echo. So this is my answer.
Thank you.
في سؤال دكتورة صفاء، واحد بيسأل عن ال artificial intelligence. What about use of artificial intelligence in the assessment of valvular lesions؟ يعني هل ال artificial intelligence عنده دخل الآن so far؟
طيب, this is a very great question, and I was actually expecting it. The best answer to this came from a lecture that I attended 4 weeks ago. The artificial intelligence, if it's used appropriately, it will improve or lessen the gap that can be brought by the human minds. A big example: you are doing an echocardiogram on a patient who has thick left ventricle and severe aortic stenosis, and the patient is having hypertension. The questions that run across your mind: is this hypertension affecting the left ventricle, causing left ventricular hypertrophy on top of aortic stenosis? Or is it just a mere aortic stenosis derived severe left ventricular hypertrophy? Or is it a concomitant amyloid affecting the left ventricle? This is one of the situations where artificial intelligence, if properly used, will highlight in the report or highlight the numbers for you, that the likelihood that provided that you did the classical assessment, يعني لو عملت proper velocities across the ventricles, لو عملت proper assessment of MAPSI, proper assessment of tissue Doppler deformation, proper global longitudinal strain, as part ما هو ده it brings you to the point of إنه you have to go by the book. اديني good study كل البارامترز فيه، وبعد ذاك انت you as the artificial intelligence will tell you beware, this patient has all the classical features of amyloid. لو عندك cardiac amyloid with severe aortic stenosis, is not going to be the same road for treating patients with hypertrophic cardiomyopathy with concomitant aortic stenosis, ولا controlling hypertension as a confounder and treat his aortic stenosis. Is going to be a worldwide different. Here, artificial intelligence it plays role, but to use the artificial intelligence properly, you have to do your job properly. Get all the numbers, get all the parameters, feed the machine properly عشان تديك a proper use of the artificial intelligence, and it is a future direction. artificial intelligence في الكاردياك MRI machine, you sit back and it gives you almost the report في يدك, provided that you did the protocol properly. and I'm sure it's going to be the very near future and in aortic in echocardiogram machines. We know about the artificial intelligence in ECGs, in documented stress echo, in all this is coming up. There's no reason why it should not be coming up in the assessment of valvular heart disease and reporting, refining, reporting further.
Thank you, Dr. Safa. Very nice explanation as usual. Welcome, Dr. Mohammed Bannaga. Welcome.
السلام عليكم.
عليكم السلام.
شكرا دكتور صفاء للمحاضرة الجميلة جدا. الله يخليك. أنا هقول لك one case جاني امبارح شفت قبل 2 days. I see one case. This is a 49 years man, non hypertension and AF when NOAC, and came with the shortness of breath, mild exertion and chest pain, and have two echo. One of the echo have severe aortic stenosis with ejection fraction 39. Another echo is moderate aortic stenosis with ejection fraction the same 38. And the consultant asked for dobutamine echo for ischemia, and so the patient is improved with ejection fraction 50%. After that we do corona angiogram and show slow flow. الدوبيتامين ايكو كان improve ejection fraction, and this is ischemia in the form the reversible in the anterior tetraris. ده الدوبيتامين ايكو. وفي ejection fraction improve من 39 to 50. لما عملنا
الاسسمنت في الاورتيك فالف، معلش الاسسمنت في الاورتيك فالف
ما كتب
كاتب
سيفير اورتيك، كاتب سيفير اورتيك، كاتب سيفير اورتيك ستينوزيس ومايلد ام ار، وكاتب الاجكشن فراكشن امبروف 39 to 50 and this is ischemia for ديبيوتامينيك. ده الريبورت كان كده. فاتعملت الكورونا انجيوجرام طلع بس برضه ده سلو فلو، فوقفنا هنا.
ليه وقفتوا؟ الراي سايد فيه شنو؟ التركز بالفالف فيه شنو؟
النورمال.
انت رايك شنو يا دكتور؟ وقفت ليه؟ هتعمل له شنو العيان ده؟
بقينا هل العيان ده يعمل له، هل هو البيشنت هو ترو يعني الايكو ده فيه مشكله يتعاد مره ثانيه؟ انه في واحد كونسلت كاتب سيفير او ستينوزيس.
بدون الستريس ايكو تعيده ثاني ليه؟
لا الايكو العادي، الايكو كاتب
شفت ده كلامي؟
نعمل اول
شفت الحاجات اللي
كالسيوم
بتتعمل دي وتقول لك
نعمل كالسيوم سكور.
شفت ده ذاته اللي بيجيب المشاكل. العيان ده انا listening to you، انت مشيت لحد القسطره عملتها له وعملت له دوبيوتامين ستريس ايكو، تقول لي وقفت كيف يعني؟
احنا بقينا نعمل كالسيوم سكورينج وبقينا نعمل كالسيوم سكورينج.
عيان عنده significant to me من كلامك عنده severe aortic stenosis. It is backward venting على الميترال فالف وcausing LV dysfunction. انا بالنسبه لي بكلامك ده العيان ده عايز aortic valve replacement، يعني هتعمل له شو ثاني؟ اللي كان عنده حاجه ثاني يعني انا غايبه علي. لكن انت رايك شنو يعني؟ تفتكر المشكله وين؟ انت كده مش خطوه، تفتكر الخطوه وين؟ المشكله كانت وين اول؟
المشكله والله صراحه ورطه او سيفير اورتيك ستينوز.
عشان كده يا جماعه شفتوا ادي الايكو حقه ومستحقه. اشتغلوا بفهم بتركيز بباشن عشان ما تدخل نفسك وتدخل العيان. هسه العيان ده مش هسه الدوبامين ستريس ايكو ده عملتوا ليه وبعدك مشيتوا عملتوا لحد القسطره، بعدين تقولوا ليه وقفتوا كيف يعني؟ دفعتوا ثمن الحاجات دي وقفتوا توقفوا كيف؟ تعملوا لحد النهايه، تعملوا له. انا شخصيا انا ما بعرف الا كان شوف صلاح الباشا رايه تاي، لكن انا شفت العيان ده كان ما عملت له ورتك باب ريبليسمنت يشتكي يقول لي يلا.
خلاص شكرا. تسلم.
Thank you very much أستاذتنا دكتورة صفاء. وأنا أفتكر أستاذنا الباشا هنا وأستاذنا دكتور عبد الرحمن موجود ودكتورة صفاء موجودة. أفتكر it is high time إن نفكر for fellowship of imaging في السودان. يعني الناس ممكن يبدأوا يفكروا فيها، تكون واحدة من الحاجات إن شاء الله اللي تتعمل في السودان الجديد إن شاء الله بإذن الله تعالى. أنا والله شاكر لك جدا دكتورة صفاء، ويعني this is more than amazing, very interesting, very delicate standard lecture, and I enjoy it very much. Everyone in this platform enjoy it. Thank you very much. وأنا أشكرك جدا. وأستاذنا بروف الباشا, please if you can conclude this session and take home message.
السلام عليكم ورحمة الله. أنا والله الحياة اللي بقول ريالي للفولو هتسمعوا الكلام ده ممكن تسمعوه منهم. قلت لهم من ما بيعرف ايمجينج هيز نوت ا كارديولوجيست. وريتهم قلت لهم ما تفتكروا انا يعني انترفنشن كارديولوجي، العكس تماما. انا بفتكر الانترفنشن كارديولوجي زي ما واحد من الفيمس انترفنشن كارديولوجي ان ايلاند مناسبه، مش ذا فيمس يعني، انا ولا زول عرفته بيلعب بالوير في حياتي والله. قال لك لو جبت قال لي بيتكلم مع قال لي جبت لي جريت من بطن امه، يعني ركبته لي طوال ما قريت اي حاجه. والله انا اعلمه لك الانترفيشن 6 months، لكن ما بقدر اعلم باقي الكارديولوجي. لما يا جماعه ما تبقوا ميكانيكيه، بي ان انجينير. ده الكلام بس عن المسيح قالته الاخ صفاء اللي بحضنك. يعني انت بي ان انجينير ولا تبقى ميكانيكي؟ انه هل الحاجه دي المفروض تجي هنا يشتكت فرزه، لانه الزول ده يعمل مشكله هسه. يعني الستريسيكو والحاجات اللي عملتها دي كلها، البيشن ما عنده مصلحه فيها الناس ولا عنده شغاله فيها. البيشن ده عنده مشكله تو بي سولف. لو ما حليتها انا افتكر يعني زي ما قال ممكن اشتكيك قدام الله سبحانه وتعالى، ودي حقيقه من الاسف. انا يا جماعه نحتاج ريالي، احنا دايرين الاخ صفاء تدينا التزام، والاخ دسوقي جاهز بالمناسبه انه نمتن لاولادنا الفلو بناتنا الفلو ده الايكو ده والله والايمجين. لو عملت دي لكفتنا الفلوشيب كلها، لانه من ناحيه كلينيكال الكيس ازاي الفوليوم ازاي، لكن الايمجين كلنا وي هاف ا ديفكتس وي هاف تو. الناس لازم تكسب يعني تقول الكلمه دي ان في الايمجين احنا وي ار نوت ا جود از كارديولوجيست في الايمجينج. الناس معروفين زي هسه شفت الطريقه اللي قدمت بها صفاء المحاضره دي، الطريقه اللي بتقدم في الكونفرنس العالميه بالمناسبه، انه زول هاضم الشيء عارفه اداك الزبده. يعني 4 فالف ريليجن قالوا لنا قدمها وقدمها لكم في 10 ساعات. شوف قدمتها لك في كيف تايم كيف، لانه هاضمه وعارفه، ودي ذا بيست الزبده قدمتها لكم. ودي الحياه الكويسه يا صفاء. وانجوي افري تايم عبده، وانجوي افري تايم. واوعدك يا دكتور عبد الرحمن كل الحاجات اللي قلتها دي ان شاء الله سبحانه وتعالى على العهد، واوعدك بمشيئه الله واحنا نقسم على الله ان شاء الله ويبرنا نتلاقى في سودان ونسمع اصوات بعض البعض ان شاء الله. شكرا جزيلا يا جماعه.
شكرا جزاك الله خير أستاذنا بروف الباشا. شكرا أستاذتنا دكتورة صفاء، وشكرا أستاذنا عبد الرحمن زيادة، وأستاذنا دكتور عز الدين، وشكرا الزملاء كلهم. وإن شاء الله نلتقيكم بإذن الله.
جزاك الله خير.